Good afternoon. Welcome to today's webinar from the Mary H. Weiser Food Allergy Research Center at the University of Michigan. We have created this monthly series to help patients and their families cope with the psychological and social challenges of living with food allergy. As the licensed clinical social worker on staff at the U of M Food Allergy Clinic, I meet with all of our patients and provide them with skills and tools to manage stress, anxiety, school, socializing, and more. My role was established through a gift from the Weiser Food Allergy Research Center, where advanced biomedical research into the origin and treatment of food allergy is taking place every day. The center, founded only 5 years ago, recently was named a Discovery Center of Distinction by the advocacy group FAIR, and added to FAIR's prestigious network of research institutions. Our clinic, whose physician-scientist partner with the Research Center, is one of only a handful nationwide to be able to include a full-time food allergy counselor. You can learn more about the Weiser Center, its founders and faculty, by visiting uofmfoodallergy.org. That brings me to today's guest, Liz Hudson. I'm so pleased Liz can be here with us today. She is a senior clinical dietitian at Michigan Medicine. She's been a registered dietitian for 12 years, holds a master's degree in public health. She has worked in ambulatory care for the last 6 years at the Food Allergy Clinic at Michigan Medicine. She provides nutritional care for pediatric and adult patients. She also is an adjunct lecturer at the University of Michigan School of Public Health, where she teaches a graduate course in medical nutrition therapy. Previously, she worked in the inpatient center at Michigan Medicine for 5 years, followed by a year as an oncology dietitian at St. Louis University Cancer Center. She is also a doctoral candidate in epidemiology at Michigan State University. In addition to her expertise in the nutritional management of food allergies, she is passionate about adolescent health, the role of our food system in impacting the environment, cancer prevention, and animal welfare. We're so happy you could be here today, Liz. Let's start with a poll question. We'd love to hear from you so we can understand who's joining us and what's on your minds. We'll refer back as we get some feedback from you. As we move through the webinar today, make sure and send us your questions using the question and answer function. We want to speak to address your concerns, and you will receive a follow-up email with the link, so don't worry if you can't take notes. So we'll move into our presentation, and we'll be taking audience questions throughout, so please answer the polls and send us your questions. Liz, we'll be talking about feeding issues and nutritional concerns for both FPIES, food protein-induced enterocolitis syndrome, and IgE-mediated food allergies. Can you speak to the difference between these two forms of food allergy?
Certainly, and good afternoon, everyone. Thank you so much for having me and everyone for joining in today. This is a great question to start with, Kim. I'll try and offer a concise response, but if folks are looking for a little more elaboration, we can certainly provide that in writing in a follow-up email. A food allergy, as we generally think of it, involves IgE. So IgE stands for immunoglobulin E. It is a type of antibody that functions in allergic reactions. So these IgE antibodies are important because they can bind to immune cells, which are really good at producing inflammatory agents that then result in symptoms consistent with an allergic reaction. IgE-mediated reactions generally result in symptoms immediately after eating the triggering food, or within 30 minutes. So definitely more of an immediate reaction, which can result in physical symptoms such as hives, swelling, itchy, watery eyes or nose, or more severe symptoms like difficulty breathing, swallowing, vomiting. Severe symptoms alone are combined with milder symptoms may be a sign of life-threatening anaphylaxis, and the treatment for this is administration of epinephrine. FPIES, on the other hand, is considered a non-IgE mediated allergic condition. This usually presents in infancy, and we often refer to it as cell-mediated. And it involves different cells than those involved in a classic food allergy. So unlike IgE-mediated reactions, IgE-mediated allergies where reactions tend to happen right away after eating the problematic food, FPIES reactions are delayed. So often 2 to 3 hours after eating the triggering food is typically what we see, but that window of time can vary. It's around 1 to 4 hours, and in some cases can be up to 6 to 8 hours delayed. That would be a little bit more atypical, but can happen. So FPIES reactions do not manifest with symptoms like itching, hives, swelling, coughing, or wheezing. Instead, symptoms typically involve the gastrointestinal system, and other organ systems are not involved. Most often, the symptoms are delayed onset of vomiting that's repetitive in nature. There are other symptoms that may be associated with an FPIES reaction that we'll discuss a little later, but often it's this repetitive delayed vomiting. Commonly, diarrhea can follow and can last up to several days in some, but certainly not all patients. And very briefly, with regard to the pathophysiology or the cause of FPIES, it's important to note that it's really not well understood. It's hypothesized that the ingestion of these food allergens causes local inflammation mediated by certain cells, which then leads to increased intestinal permeability and a fluid shift, which can result in most often the vomiting that we do see. We think that this intestinal permeability improves over time. That's why even around age 1, we see that the risk of having a new FPIES reaction is significantly reduced compared to earlier in infancy. And it's important to note that epinephrine is not used to treat FPIES. Again, this does not involve that IgE process. We often treat an acute FPIES reaction with a drug called Zofran, which is an antiemetic, meaning that it will help stop nausea and vomiting. And then the goal is to rehydrate the child. So sorry, that was not concise, but we can move on. And if people want a little bit more detail, we can provide that in writing.
Oh, I think that's extremely helpful, because the more that people can understand about why, when they hear other people talking about their food allergy, it's helpful if you're dealing with FPIES to understand you're looking for different things and you'll be experiencing different things with your child. Melissa, can we get the results of poll 1 again? Thank you. So it looks like, so in terms of biggest concerns, child's nutritional status, and I think that is what we consistently hear at the clinic. Parents are very concerned about, what should I do? What is the best thing to do? What is the next thing for me to do? The possibility that my child will develop future food allergies looks like a lesser concern that FPIES won't resolve. And we're going to be talking about that a little bit in terms of statistically and clinically, what do we expect to see? Picky eating, we'll be talking about that a little bit more, some strategies, and that this limited diet will continue into adulthood. So any surprises there for you, Liz?
A little bit of that. The biggest response was concern over whether or not kids grow out of FPIES. And we can talk about that, or I can brush on that at any time. But that I will definitely address, because we do have very good information about that.
Excellent. So you work closely with our families after FPIES diagnosis. What are some of the reputable online sources that you share with families? And also, can you talk a little bit about your role during that year, 2 years or so, when you're working closely with a family? What might that look like?
Sure. So for starters, I have a slide here with a couple of resources. I would hesitate to recommend ever just Googling FPIES. You're going to find lots of things that kind of fit under this FPIES umbrella that really is not FPIES. So I would really start with the International FPIES Association, which can be found on fpies.org. They were kind of the leaders in getting reputable information online about FPIES, and they have a ton of great resources on their website. The first ones to offer some nutritional guidelines in FPIES that I still refer to today, so very helpful. And within that site, you can also link to FPIES University, which has lots of free videos and, again, tons of information. So I would definitely start there. Kidswithfoodallergies.org is also a great resource for FPIES and food allergy in general, but specifically for recipes. But again, I would recommend starting with fpies.org and until you're able to meet with your allergist and hopefully a dietitian as well. It's really important in terms of the care and management of FPIES patients. I work very closely with our FPIES families from time of diagnosis until children grow out of FPIES, which they do grow out of FPIES, I will say that. So, you know, there's not a whole lot of skin testing involved. This, again, is a different kind of food allergy. So a lot of it is monitoring growth, food introduction. So a lot of that is done by me in my role in the clinic. So although I see all types of food allergy patients, the vast majority of what I see or my biggest workload or patient load are FPIES families.
Mm-hmm. What are some of the nutritional concerns that you hear from parents and caregivers as they're navigating FPIES?
Sure. So nutritionally speaking, the most important factor is achieving and maintaining adequate growth, which is usually very much possible with FPIES. It's important for us to remember that during infancy, breast milk and or formula are providing all or most of the nourishment that is needed. So even with the most limited solid food diet, children can achieve good growth and develop feeding skills. So faltering growth would be the biggest concern, but you asked the most common nutritional problems that parents ask about. And most often it's families worrying about whether their child is eating enough. But with a very consistent growth pattern, we can see if a baby is getting enough to eat. Also, iron intake is a big focus. Breast milk is low in iron, which is an important nutrient for infant growth and cognitive development. So if a mother's iron stores during pregnancy were sufficient, a baby is born with iron supply that will last until the 4 to 6 month range. After this, an additional iron source is required, which is why we often start with solids that are iron fortified infant cereals. But in most of our FPIES patients, we have to avoid grains for a period of time, as rice and oat are the two most common solid food FPIES triggers. So making sure infants are getting enough iron is important and is something we prioritize. Other concerns may be food acceptance, getting them to take solids, advancing textures, getting enough nutritional variety. So we discuss all these things, monitor them very closely to ensure they're growing well, getting some good nutritional variety in their foods, and meeting their feeding development goals.
Thank you. What are your recommendations? How do you go about helping families introduce foods? I know that is top of everybody's mind, is how are we going to get them to have as diverse a diet as quickly as possible? So how does that work?
Yeah, I think, I think what's difficult, especially for families when they first have the FPIES diagnosis, is as parents, the most natural thing is to be able to feed your child. And sometimes they feel that has been taken from them, especially if there's been maybe 2 reactions to 2 different foods that happen right in a row. So we do have a slide on this. So as you can see, we recommend a relatively conservative approach to food introduction. So we're going to start with foods that are considered low risk, meaning in our clinical experience, but also in studies looking at FPIES, these are foods that do not generally trigger FPIES symptoms in the majority of patients. So as the slide shows, we introduce foods one at a time over 5 to 7 days. So this is a little longer than we would typically introduce foods in infants. We start with a very small amount on the first day, you know, a pea-sized amount or a half a teaspoon. So essentially just a bite of the new food, and gradually increase how much is offered over 5 to 7 days. Sometimes we may go longer and extend that trial to 10 days. That's not typical. Usually 5 to 7 days is sufficient to determine if the food is safe. And sometimes if a child is doing really well and passing a lot of foods, we can shorten the food trials. We do like the foods to be in single ingredient form when first introduced whenever possible. So we'll start with a handful of low risk foods with the goal of preventing another FPIES reaction. And you can see some examples of some low risk foods on this slide. Parents do not have to exhaust this list. We generally pick 5 to 6 low-risk foods, often prioritizing a few that are rich in iron. So once a handful of low-risk foods are tolerated in a diet, we can move on to trialing some moderate-risk foods, which you can see some examples in the next slide. These lists are not all-inclusive, especially with regard to low-risk foods. There's lots of low-risk foods. So parents can also offer input on maybe common foods in their household that they would like to try. So if it's not on these lists, you know, there are plenty of things we can try, and we can discuss introducing what works best for them.
So as they're introducing foods, what should they be looking for? What are the symptoms? I know they're different than with IgE mediated food allergies. So what are symptoms of a FPIES reaction?
Yes, so most often, again, we are looking for delayed repetitive vomiting. So really in that 1 to 4 hour mark, as I mentioned, for some it may be, you know, 6 to 8 hours after the food, but that's an atypical presentation. And it really needs to be repetitive vomiting. I know that sounds weird to say it needs to be, but vomiting more than once would be more indicative of an FPIES reaction. You know, for instance, if I get a call from a parent that they're trialing a new food, and an hour later their child vomited once and then it stopped, and maybe they had just taken a really big bottle and then they were kind of roughhousing with their sibling. Probably, you know, I'm not too concerned that that's FPIES. We might cautiously try the food again the next day and just watch it, but the repetitive vomiting is kind of that hallmark feature. Other less common symptoms may be an increase in reflux or several days of runny stools. These can be more mild symptoms and we'd want to know about it, but it may not mean there's an FPIES reaction happening. So we may discuss with the family and decide to continue moving forward with the food trial, maybe cut back on the volume of the food offered for a day or two. But I would not say those symptoms necessarily mean that a food is a fail, but those are some milder symptoms we may see. Briefly, FPIES can also present in a more what we call chronic presentation. This is less common and more often associated with cow's milk formula or soy formula. Those symptoms can be rather nonspecific, but may include intermittent vomiting, diarrhea that may or may not contain blood, and poor weight gain. So the poor weight gain is kind of this differentiating feature that we would look for in a more chronic FPIES presentation.
So it sounds like, you know, people are going to be looking for the symptoms that you talked about. I think it's a great time to talk about, so if there is a diagnosis and they have Zofran on hand, how do they know when to treat?
Yeah, by the time, unfortunately, by the time you come to see us or you see me, you will have likely seen what an FPIES reaction looks like. So I always empower parents, you know, you've seen it, you know kind of what it looks like. That doesn't mean it's going to be exactly that same time frame the next time, but Again, in that 1 to 4 hour window, if there is repetitive vomiting, especially when a new food is being trialed. It may not happen on day 1. That's why we do 5 to 7 days. It could happen on day 4. But we wouldn't expect the repetitive delayed vomiting to happen when all safe foods are being fed. It really needs to be during a new food trial. So at the first sign of that repetitive vomiting, so vomiting more than once, we would recommend that you give the Zofran. If that does not stop the vomiting, then we do recommend you go to the emergency room. If you treat with the Zofran, the vomiting stops and your child is able to rehydrate themselves, either start nursing, take a bottle, take some unflavored Pedialyte, and no more vomiting persists, you can probably stay home. We're always going to say go to the ER, but in that situation, if the vomiting does stop and they're able to rehydrate themselves, you could stay home, and then you'll let us know, that there was potentially a reaction.
I'm sure that that's very reassuring to families to have that idea of what to look for and how to treat. So we have a question from Holly. How much iron do they need? And I'm sure this varies at different ages, but what would you tell parents at different ages, how to know that?
Yes, it does vary depending on how old they are. And again, most kids, I don't want to get caught up in milligrams of iron, how much they need. What I would say to moms that are continuing to breastfeed, and if, let's say, we cannot introduce grains yet, I would tell mom, keep taking your prenatal vitamins. And then we're going to really prioritize, starting some iron foods with the infant. So maybe quinoa, maybe spinach, maybe even we do an animal protein earlier than we would. So if we can get a handful of iron-rich foods in the diet consistently, that's great. Let's say they don't do so well with those foods or they don't accept them, then we'll probably have you start them on a liquid multivitamin that contains iron until we can get them consuming a diet that has more iron-rich foods in it.
So we have another question. Due to our FPIES and peanut allergy diagnosis, it has been recommended that we delay other high-risk food introductions until a year. That seems to go against some new research about trying to introduce allergy risk foods earlier.
Yes, so FPIES can throw a wrench into early introduction of common food allergens to prevent developing an IgE mediated food allergy. I think specifically you said this family is dealing with a peanut allergy. Yes. So similarly in FPIES, peanut is a higher risk FPIES food. So those families that maybe want to get peanut in the diet early, that can be difficult because it's also a high risk FPIES food. Same goes for things like egg or fish or shellfish. We usually wait till after age 1. What I would say is, and we have a slide on this at the very end that kind of shows, based on the research, what type of infant really benefits the most from that very early introduction of allergen. So I don't want, yes, so you can see this here. This is specific to peanut. This is based on kind of that, kind of a groundbreaking study that came out, 5 or 6 years ago. So parents really worry about this, trying to get these allergens in early, but for kids that have a food allergy or who have FPIES, it can be more of a risk. So if we say wait till age 1, where we can then start introducing things like egg in an FPIES patient, that's still pretty early. So I want you to think of that as still relatively early introduction. When we look at the studies that talk about delaying allergen introduction, it was delayed like at age 3 or 5. So we can still present these allergens relatively early, but in a safe way now, given their allergen risk and their FPIES risk. So talk to your allergist, you know, talk to your dietitian. We can come up with a plan, you know, to safely introduce these foods, get them in early, as early as possible, without really increasing risk of having another allergy reaction, whether it's IgE or FPIES.
So when you talk about, you know, it's so important to be able to work with a dietitian when managing food allergies, but in particular, this FPIES, the introduction of foods, monitoring of symptoms, and sort of knowing where to go next. If they are not a Michigan medicine patient, how can they talk to a dietitian?
Sure. So I can definitely provide a link. I think I had mentioned to prior to this webinar that I could provide a link where you can find a dietitian near you. Unfortunately, there's not a lot of dietitians that specifically work in food allergy. We kind of are lucky at Michigan Medicine that we are able to staff me, you know, just I specifically work in food allergy. I will say, you know, especially now with telemedicine, I am working virtually. Patients do not have to be established with an allergist at Michigan Medicine to see me. I get a lot of self-referrals. You don't have to see a physician at Michigan Medicine. You would have to get registered so you're in our healthcare system, but you know, patients can self-refer to me. They can get a referral from their doctor to me. Some allergists, if you have an outside allergist, they may have a dietitian that they specifically refer to because they know that this dietitian sees patients with food allergies. So always ask them. A lot of, if there really is no one, just ask for a pediatric allergist or a pediatric GI allergist. So someone that specializes in gastroenterology will probably have some background too in allergy.
Oh, thank you. I'm sure that's really useful. So if people are seeing like an allergist in private practice, they may not even be aware that dietitians work closely with patients in moving along and at different points in IgE mediated food allergy as well. It's really important to have. So I hope people understand, you know, they can reach out, they can call Michigan Medicine Allergy, they can ask about that, and also look for that link in the email that you'll receive to get those resources. So let's get back to around being able to feel like you're safely feeding your baby. The question of, should breastfeeding moms exclude the FPIES triggers from their own diet?
This comes up all the time, and the short and quick answer is no. Breastfeeding moms do not need to remove FPIES triggers from their diet. FPIES reactions via allergen transmission in breast milk is thought to be an exceptionally rare occurrence. So studies and our clinical experience show that no maternal avoidance while breastfeeding is required for most. There's always exceptions to that. But in breastfed infants who only react to food upon introduction into the infant's diet, maternal avoidance is not required. In exclusively breastfed infants or infants where symptoms started while exclusively being breastfed, maternal avoidance of the allergen may be required, particularly in the case of a chronic FPIES presentation, which I know I didn't elaborate a whole lot on. Again, this is less common, more difficult to diagnose. So I don't want to spend too much on chronic FPIES, but that may be a situation where mom may need to avoid some foods or consider transitioning to a hypoallergenic formula. In very rare cases during breastfeeding, intake of large amounts of the causative allergen by mom may lead to acute FPIES symptoms. I have never seen that in my clinical practice. It's been reported, but highly unlikely. So in general, no maternal avoidance is necessary while breastfeeding the infant with FPIES.
So did we have a second poll? I know we want to find out who we're talking to. Excellent. So if we could get some more information about who's tuning in today, both, so answer, as many as apply to you. So if you are a person with IgE mediated food allergies, we'd love to know who's joining us. And if you are a parent or caregiver, we'd really like to know what specific things that you're dealing with. So Liz, how likely is it that if there's been an FPIES diagnosis, that they're going to find out that the child has multiple triggers?
So yes, parents always want to know, and we cannot really predict who will have multiple FPIES triggers yet. Hopefully, we have some studies underway for some methods, hopefully, to determine that, but very, very early on. The majority of what I can say is that the majority of children with FPIES will only have one trigger, with the next majority having two triggers. So it's much less common to have more than two triggers. It happens for sure. Some of you out there maybe have a child that has had multiple, 3, 4 triggers. So it does happen, but most will have one trigger followed by less having two, and even fewer having more than two. We tend to be better at identifying FPIES earlier and more accurately. So we can implement the steps I talked about earlier with starting with low-risk foods, avoiding high-risk foods until age 1, hopefully to prevent another reaction. So we've come a long way, even 5, 6 years ago when I first started. Pediatricians, and this is because it was a newer condition. I'm not saying that this is just how a condition evolves. We're not well versed in FPIES. They didn't see a lot of it. They didn't know what it was. So they would, if a patient called and said, my child had this vomiting to rice, they may say, oh, try it again. Same thing happens. They say, okay, stop the rice, try oatmeal. And then it happens again because rice and oat are the two most common. So we're better at really understanding FPIES clinically so we can capture it quickly. They can come see an allergist, hopefully see a dietitian, and we can implement some steps to hopefully prevent another reaction.
Oh, that's great. So let's see who's tuning in. So a lot of parents or caregivers, children with FPIES, and it looks like, so diagnosed with both, and that's my next question. How likely is it if a child's diagnosed with FPIES, the first thing I always hear is, does this mean they're going to have food allergies for the rest of their life? Will they have the IgE mediated food allergy? What are your thoughts on that? What do we know about that so far?
Yeah, so this is such a good question, and I wish I had better data to give a good response. The short answer is that there is possibly an increased risk of a child with FPIES to then develop a true food allergy. And when I say an increased risk, that's compared to like the general population. So maybe a slight increased risk from what we can tell. Again, different allergic mechanisms happening. I wouldn't consider FPIES, and I hope this is an accurate statement, an atopic disease where we think of things like eczema, food allergy, asthma. Those kind of involve similar mechanisms. FPIES is different. So potentially a slightly higher risk. I think the most we've seen is in children that have FPIES to milk. So they may be exposed to like cow's milk formula very early on in infancy. They have an FPIES reaction. We take it away for an extended period of time. And then when we go to maybe reintroduce milk or test them first, this time period that they've been avoiding it, they then become sensitized or have developed a true food allergy to it. Not common, but of the FPIES triggers, that's probably where you see the greatest risk of it turning into a true food allergy. But I would say vast majority of kids grow out of FPIES with no food avoidances, no lingering food allergies.
Oh, I'm sure that will be very reassuring. We have a question from a mother of an 11-month-old with FPIES. With regard to picky eating, sometimes I feel like I need to get a particular puree in her because that's how the food comes. She will now eat almond yogurt by spoon. She will also take a tiny bit of puree with one of these feeding pacifiers, or if I feed her by straw. I know not to force things, but do you have any other tips?
Sure. I've been seeing this a lot. Maybe it's just because I see so many FPIES, but especially at 11 months, I would try offering different textures. So some finger food, some kids totally bypass purees. They may resist them, not really accept them, spit them out, and then when they're kind of developmentally ready, they go to town on some soft solids, mashable foods, finger foods. So try playing with the texture. You can start with a thickened puree and then one that has some soft lumps in it. Then little pieces of soft mashable foods, and then some crispier finger foods as they're able to tolerate. So I would play around with the textures, and if your child really at any age, of course, very early we're going to start with thin purees. That's the safest, but see if they're ready to kind of try some different textures. Some kids really don't love those purees and they're ready for some more table foods.
So let's revisit this idea of if you do not introduce the foods that have a potential high allergic reaction, isn't there a higher chance that a child will have a reaction to it, such as eggs and peanuts?
Okay, so if you don't, potentially, and this, again, it is more so for a specific infant. And when I say a specific infant, it would be an infant who is a high risk for an allergy to begin with. So they might have really significant eczema as an infant. Maybe they are diagnosed with a food allergy very young. So these are the types of children that we usually will screen for. So we'll do some food allergy testing when they're very young, with the idea that they're at a high risk to be a food allergy patient. We want to get them exposed to this food protein early. For the general population, or let's even say for the FPIES infant, if we are waiting to 11, 12 months to introduce peanut or egg, I don't think we can say that we're increasing their risk to develop a food allergy by waiting that long. I really don't. We don't have data to support that. It would be more so like, let's say if we waited till age 3 or 5, that their risk would be slightly increased, again, slightly increased compared to the general population. But there is a very, high risk allergy kids are who benefit from that very early introduction. Otherwise, talk to your allergist. I always say, nudge us if you think I really want to try egg with them. Okay, maybe we can try some baked egg first, and for a couple of days, if that goes okay, we'll do some really well cooked scrambled egg. But usually we're going to say let's wait till age 1 in the FPIES infant. But for peanut, and this is specific to FPIES, it is a high risk FPIES food. I have a whole kind of plan to get peanut in by 11 months, which is still considered early introduction. We'll start with a very low risk legume, like a black bean. And then if that goes okay, we'll try a moderate risk legume like green bean. And if they pass those two, so passing foods from a certain food group really shows us that they're probably going to do okay with other foods from that food group. So then we'll try peanut. So there are things we can do, like I said, to get these foods in early, but I would hesitate to say that waiting till age 1 in most food allergy kids or FPIES kids, that is not putting them at risk to develop a food allergy to those foods that we're avoiding until then.
So their experience might look a little different than some of their friends with children the same age. And I think that brings up some anxiety for people. It's,
It
am I doing the
does.
right thing?
I don't know. I mean, time permitting, if we can look at that one slide again that shows the early peanut introduction. Let's see.
And we have another question. It sounds like revisiting the idea of, so our allergist who specializes in FPIES told us to try eggs, and when he was first diagnosed, he had had a severe reaction to oats. He failed eggs and was only 7 months old. He's now 10 months, and I see you recommend eggs at 12 months. What should they do? Should they try it again? Should they keep avoiding it?
So again, we tend to take, I would say, a conservative approach, but it is on par with what other major national centers do for FPIES. We are going to have, once a child has reacted to any food, had an FPIES reaction, we're going to avoid any high-risk food that they have not had until age 1. So let's say a child reacts to oats, but maybe they've already been eating rice and they tolerate it. We're not going to say remove rice. We'll say keep feeding them rice. But any other high-risk food like milk or dairy, soy, eggs, sweet potato, banana, lentils, green peas, chicken, these are just an example of some high-risk FPIES foods. We're going to wait till age 1, and then we'll try them around, the first birthday, and we'll do it cautiously and probably in the home setting. So no need for like an oral challenge, but in this case, since they've shown an FPIES reaction to egg, I would recommend waiting. You're going to probably wait close to like 18 months before you try egg again, and that really should be done in the office under physician supervision when you reintroduce it.
And might that be like a baked egg scenario and build up, or what might that look like for that family?
Yeah, that's a really great question, Kim. So unlike an IgE mediated food allergy, where we can check different components in the blood of, maybe this child will tolerate baked milk or baked egg. For FPIES, it's really baked or not. Exposure to that protein, if it's going to be a problem, will be a problem. So sometimes we'll do baked egg, but not in a challenge. If we're doing an FPIES challenge to egg, it'll be probably scrambled egg. We're just going to go for it, because whether it's baked or not really shouldn't make a difference with FPIES.
That makes a lot of sense. I'm not sure, I didn't want to stop you from, was there something on the slide you wanted to?
Yes, I know parents, they get so much anxiety about this early introduction. So if you can see on this slide, again, this is derived from this study that looked primarily at peanut. We also have studies on early introduction of egg and others. So if we look at infant criteria, they have severe eczema, an egg allergy, or both. So they've been determined to have an egg allergy. The recommendation is that they get some testing done first. And based on that results, we're going to introduce peanut around 4 to 6 months. So this is that group that's high risk that we really want to get the peanut in early. And we will do testing first. If that skin test or blood test is positive, we may introduce it in the office as opposed to letting you do at home, or if the allergist is really concerned, we may not introduce it at all. Mild to moderate eczema, that criteria. We're going to introduce peanut containing foods at around 6 months of age, no testing required, we're just going to give it to them. Let's say there's no history of eczema, no food allergy, we're going to introduce peanut containing foods whenever family preferences. So not a huge push to do it early because they may not benefit. So this is kind of just whenever the family feels appropriate or what's in accordance with their practices. These guidelines are not super helpful and specific with regard to what to do with FPIES, but again, we have some techniques in place to try some other legumes and then get peanut in by that 11-month mark. This also doesn't specify what to do if a sibling has an allergy, so these guidelines aren't perfect, but talk to your allergist. And this third criteria, so no eczema or food allergy, you can do at 6 months, give peanut. And I think we'll talk a little bit about how to do early introduction of these allergens. I have a couple of tips, but again, it's a very specific population that's already at high risk that really benefits from that early introduction. So if you're not quite early, what we call 4 to 6 months, it's going to be okay. We can still get it in early enough, I would say.
Mhm. So while we're talking about food introduction, I think this is a great question. What advice do we have for parental anxiety surrounding introducing new foods? I'm anxious every day waiting to see if my child who has FPIE or will have an FPIES or IgE reaction when trying new foods. So
Yeah. What I try to say to parents is, especially with FPIES, you know what to look for, you know how to treat it, you have the Zofran. If that doesn't stop the vomiting, you go to the ER. All they're going to do there is give some fluids and maybe some more Zofran. So I try to empower them. And then I do tend to find with our low risk kind of model, starting with low risk foods, getting a couple foods that are passes and safe in the diet really builds confidence. Like parents just totally change from like the first time we see them to even a couple months later when we've gone through a number of food trials and they've gone okay. With regard to IgE mediated, you know, we'll just talk about what to look for. You know, again, empowering parents to know what a reaction looks like. Maybe we'll have them just try a very small taste at first, watch their child for 10, 20 minutes. If it looks okay, keep feeding them. We don't want to not do solids. So, you know, we always want to keep introducing food. So that's important. So we'll talk about that. But just empower yourself. Your instincts as parents are good. You know when something is not right. Maybe it's not textbook like the symptoms I told you here, but if something is not right, know how to treat it. And if you don't know how to treat it, call your allergist, call us. You know, our food allergy nurses are really helpful. Kim is fantastic if there's a lot of anxiety around, you know, introducing foods. So empower yourselves and work with us as a team, and we'll help you through it. But it will get better, I promise. It will get better.
absolutely. And I would add, be careful also where you're getting your information. We want you to always make sure you're getting reliable, accurate information. And sometimes we talk to families and, you know, you've gone into a discussion group, you found something, and then we get a call because it's really fueled your anxiety. So I think what Liz talks about, you know, really think about what you know and what symptoms you're looking for, remind yourself. So if you already have an FPIES diagnosis and you're working through introducing foods, as she said, you're never going to be in that exact same situation again where it was entirely unexpected. You didn't have medication. You didn't know what you were seeing. So remember, as I introduce foods, I do have the medication. I know the symptoms to look for. We know what this is. It's never going to come as such a shock. And so you are more prepared. With IgE mediated food allergies, if you've already had a diagnosis, same thing. You have your epinephrine, you know the symptoms to watch for, you have a plan. And our allergists always reinforce with families this, remember, you know, do the plan, follow the plan. You're never going to be in that situation again where it was the first time and you were taken aback. So if it is the first time, Liz, they're introducing food and it's not an FPIES reaction, but more the IgE mediated. What do we say to a family about how to respond?
Sure. If it's, you know, kids with allergies, like a true food allergy, sometimes have eczema, maybe really sensitive skin. Some kids can have just some contact irritation if the food gets on their face. If you wipe it away and it kind of goes away on its own, you know, keep giving that food. It's okay. If there's hives or maybe a little bit of sneezing, coughing, kind of mild reactions, Usually this can be treated with Benadryl. Again, I would talk to your allergist, but if it is ever more involved than that, so if it involves two organ systems, so maybe hives and the lips and the tongue are swelling upon eating that food, you're really going to want to administer epinephrine and call 911. If it's hives and they vomit, epinephrine, that's, you know, two organ systems is really kind of considered anaphylaxis. We'd want to treat with epinephrine, not just Benadryl. A lot of times parents will say, you know, I fed them, you know, grapes, and the next day they woke up with a rash. It's probably not due to a food. You know, it's, again, IgE is usually immediate or within 30 minutes. So a really delayed kind of rash like that is likely not a food allergy, probably something in the environment.
We're getting great questions from the audience. So
I see those. I could answer two of those probably pretty quickly.
Sure, please.
If that's okay.
Yes.
So somebody's asking if chickpea is a high-risk food and should be avoided to age 1. It is not a high-risk food. This is not going to be consistent across allergists. I know I work with one allergist that does have people wait till after 1 to do chickpea. I would not. I think if your child tolerates some other legumes, especially another higher risk legume, let's say they have green peas in their diet, peanuts, lentil, try chickpea. I would just trial it. Start with that kind of conservative 5 to 7 day trial. If they tolerate another dried bean like a black bean or a pinto bean, don't assume that you can just give chickpea. I would just trial it, but you do not. I'm saying you do not have to wait till age 1 to trial chickpea. Just do it cautiously over 5 to 7 days. Quickly, how long do you recommend doing gut rest after a reaction? So after there's an FPIES reaction, I say wait till your child is back to a baseline for them, because some children will have lingering diarrhea for a couple of days. So until they're back kind of stooling normally, eating normally, or if they kind of bounce right back, some kids, they vomit a couple of times and they're fine. So if there's no lingering effect, then usually we say wait 4 days, and then you can try and go on to your next new food.
So there's a question here about why isn't the dissolvable Zofran recommended for children under 3?
I'm not sure. That's a good question. I wish I could ask our pharmacist. I'm really not sure. Another recommendation that, again, is not consistent across allergists, some may say different things. If you administer the Zofran and your child vomits it up, we will recommend waiting 10 minutes and then you can give another dose. Some allergists will say if you give the Zofran and it doesn't stop the vomiting, go to the ER. Others will say, wait 10 minutes, give another dose. And then if the vomiting doesn't stop, then you need to go in. But I'm not sure why the dissolvable is not recommended for children under 3.
So a conversation with you would not be complete if we did not address picky eating. Because it comes up and it's a huge concern for parents. It's people worry that they're not getting all of the nutrition, and we also hear, I'm concerned that they're going to have a limited diet moving forward. So, of course, many individuals with food allergies that we treat at the clinic are described by their parents or themselves as picky eaters. And I've heard you say that early feeding experiences set the stage for accepting food later in life. Parents often verbalize the concern that they'll miss out on enjoying food. And what approach do you suggest to parents and caregivers of older kids who insist on a very limited diet?
Yeah, I would start by saying ask for help or bring it up during your visit. Don't just chalk it up to, oh, they're a picky eater. We would want to know, because we do have some ways we can help. There are certain ages where picky or selective eating is common and tends to kind of resolve with the child becoming more willing to accept foods over time. kids may really want the same foods for a while, but it is important for parents to keep offering a variety of foods. Tastes and preferences of young children change rapidly. So something they didn't like 2 weeks ago, they may be more accepting of this week. And sometimes you have to offer it many times before it's accepted. I know parents get tired of us saying that, keep trying, but sometimes that's really what it is, keep offering. In our older kids, if there really is a limited range of foods that they're accepting, we're going to want to know about that. We can work to expand the diet. It may take some time, or there may be something else going on that's causing or contributing to this really picky eating. So we'll be able to help with that, or at least bring people on board that can also help with that. For our younger kids, there's really great resources out there. One of them is, and I should have included this, but ellensatterinstitute.org. So Ellen is spelled Ellyn. Last name is Satter, Satter. If you just Google her, she's kind of a feeding guru in a sense, and has some really good helpful tips and kind of philosophy on her website. And it's important to note that if multiple food allergies are diagnosed in very young children, their oral motor development can be affected. So the development of mature oral motor skills coincides with the time that most major food allergens are introduced. So for children with food allergies who have repeated negative experiences associated with eating, this can result in altered feeding practices that then can persist into their teenage years. So these may be delayed or impaired developmental chewing skills, gagging or spitting out or choking on solids, poor progression with solids, relying on pureed or soft solid textures. So, we kind of want to know all about this. We can be proactive in referring to a behavioral feeding program. In our older teens teenage kids or school-age kids that are very limited in the foods they'll accept, we can, sometimes I'll implement something called food chaining. So this is where we'll kind of look at the foods that they do have and they are accepting of, and kind of work from there to build off of that and offer similar foods. So it's this whole kind of technique. And so we can work with, those types of methods to expand diet. But in short, let us know. There's lots of resources out there. Even at Michigan Medicine, we have something called Picky Eaters Anonymous. It's a group run by one of our excellent pediatric dietitians on picky eating. So it's very common. It's a lot of anxiety for parents, and so we want to know about it and we can help address it.
Oh, thank you so much, Liz, for being with us today. We're out of time, and I am sure that you address so many concerns that families thought maybe they were the only one worried about this. So you will all get an email with the really terrific links that Liz mentioned, so you'll be able to follow up. And again, if you haven't had the opportunity to work with a dietitian who's really skillful in food allergy nutritional management, please call the clinic, and perhaps it's appropriate for you to have an opportunity to speak with Liz. And if you're working with an allergist elsewhere, reach out, because again, there's a lot more to good food allergy management than just the medical management. So we want you to get what you need. So we thank you. On behalf of the Weiser Center, thanks for being with us today. We hope that we'll continue to grow this audience of not just our patients, but patients across the country, so that there can be a community of people who are learning together and hearing each other's questions. So we're going to go into a brief practice. We end every one of our webinars with some sort of stress management practice. So thanks everyone who participated. And we'll take a few minutes if you're able to stay. So this practice of mindfulness that you've heard about, I'm going to show you
Sorry, Kim, you got muted.
Okay, so I'm going to show you how easily we can bring in the practice of mindfulness into our daily life. So as we are just here in our seats, notice the feeling of your breath. Just connecting with the feeling of your breath. Notice your body. And follow the sensation of your breath as it goes in and out. Just bringing your mind's attention to this feeling. The fullness of the inhale and breathing out through the exhale. You may even add a color to the feeling of the breath in your mind. So for some of our younger viewers, if your favorite color is blue, yellow, red, think of your breath as being that color and feeling yourself breathe from the top of your head, breathing in that beautiful color out through your chest, your stomach, down your legs, out through the bottoms of your feet. Notice when your mind has wandered away and just gently bring it back and find the next breath. We can do this as we sit down to eat breakfast or dinner, as you lie down at night to go to bed, taking a moment and just putting your hand on your belly, feeling the rise and fall of your breath, and remembering you can come out of your thinking mind just to notice, how does it feel to be in my body? How does it feel to be breathing? And as kids are going to be returning to school, whether that's online or in class, remember we can use these practices to deal with stress in dealing with schoolwork or stress of, getting back into the routine. So just as you sit maybe in front of Zoom, remembering that you can check in, just feel yourself breathing. And from the top of your head, through your body, out through the soles of your feet, just really getting that sense of being back in the present moment. So we thank all of you, and we look forward to next time.